Be with you guys in just a minute, okay?
Okay.
Good morning.
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 Okay, good morning, everybody. Glad to see everybody got up pretty early on a Saturday morning. So I'm Professor Dunham, and we're going to have a review. Now, this is your last exam, so make it a good one. Everybody got thumbs up on that one? All right, I know you can do it. All right, thumbs up. Oh yeah, there's Pauline. Hi, how are you? Good to see you again.
Good morning. Good morning. Yes.
Yeah. So if I ask you a question, what are you going to do?
Answer?
She gets an A. Okay. All right, so let's have some fun on a Saturday morning and go over these chapters. And I'm going to give you quite a few questions and see how you're doing. All right?
Okay.
Okay. So let's see this cover. Let me make sure I got this correct. Exam 3, week 7 and 8. And week 7 is chapter 10. And then we got chapter 12, 13, and 14. Okay. All right. I'll kind of tell you how the blueprint of this test is so that you can kind of gauge how many, questions and what to focus on. How about that? Okay. All right, everybody. Get your thinking caps on. You're all nurses. I need you to think like a nurse. And let's go ahead and get started. The first chapter is what? Complications. Complications after woman with after birth. Let me ask you, come on, guys. What's the biggest problem after someone delivers?
Postpartum hemorrhage.
Yeah, postpartum hemorrhage. Okay. So, hey guys, if you're gonna be in my class here, let's go ahead and put the cameras on, okay? Because I like to see you. You're seeing me. I like to see you. Okay, thank you. Hey, Geraldine came in. I see. Yeah, I like to see you guys. It's our last review.
I'm at work. Will that be a problem if I don't have my camera on?
No, just show me your face real quick, though, so I know who I'm speaking to. Can you? Okay. All right. I give you credit for being at work and trying to do this too. Okay, so hemorrhage. Hemorrhage is your biggest problem, and we have it divided in two different areas: early hemorrhage and late hemorrhage. So let's go ahead and share my screen because it kind of keeps me on track. But stay with me, okay? And I'll come back to you. I got a lot of PowerPoints I can share, but this is the latest one I put together. And let me go here. All right. So when I say early, that means it's in the first 24 hours after she delivers. Okay. Remember, all the time, there's a lot of blood inside that uterus, right? And when she delivers, it has to go somewhere. So it has to come out. But we want to make sure that she doesn't bleed continuously. We want to make sure, what do you have to make sure that's firm? Come on.
The fundus.
The fundus. The fundus, the top portion of that uterus, it has to be very firm, okay? Otherwise, what happens? She can bleed out, all right? And if she goes into a full PPH, she can have what? What's the risk factor to that? Hypovolemic. Yes. So what is your patient presenting with when she goes into hypovolemic shock?
Tachycardia.
Tachycardia, right. Mm-hmm. Right. What's the next one? You tell me. Read it. It's right on the screen for you.
Falling systolic blood pressure. Also pale.
Okay, pale, cold, and clammy. Okay.
Mental status changes.
Yeah, if by that time you're in trouble. And then, of course, the kidneys will shut down, okay? Because I'm gonna tell you, it's in any patient. This is any patient, guys. All right, that you have a bleeder. Say you're working in ER and you have a gunshot wound come into your ER, right? They go into shock. The same thing. They get tachycardic on you, their blood pressure is going down, and you hear all the commotion, and then their kidneys don't put out. So, because when you're in shock, the body is trying to replenish itself. So that's why your heart is working really hard. And when the kidneys sense that more blood needs to be shunted to the heart to keep it going, that's when the kidneys go down. Now, that's a good all but apply question. Hint, hint, all but apply question. So I definitely would, write that down if you're not too solid on it. And this one, I think you got this one. All right. This is a good, as I said, it's a good question. The first sign of hypovolemic shock is most often what? Pauline, what is it? Tachycardia. Okay, good.
Yes.
All right. Okay, now, so there's a good question, and they always like to throw this in, and so does Hesse, is on uterine atony or atony. Okay? Yeah. All right. What does that mean to you? Now, you just wrote a discussion paper on this. What does that mean to you?
That the fundus is not the uterus is not contracting.
Right, exactly. It's soft and it's boggy. I tell you what, being a nurse, I've been in that position where you go in and your patient is laying in a pool of blood, and I dive right into that uterus, and I'm putting my hand on her, and it's soft. I can hardly feel it. I go way deep, okay, in order to get it. That's why patients, you can't teach her how to, make sure massage her fundus. You have to do it. You got to get in there, and if it's soft and boggy, what are you going to do? Start the massaging and get help. Good. Yeah. That was a quiz question. All right. So you're going to see a lot of blood. Okay, a lot of blood. And it may have clots. All right. And so you want to make sure you massage that fundus. All righty. Here we go. Here's a brain teaser. So which medication will a nurse anticipate prescribing to control postpartum uterine atony?
Number 3.
Methogen. Right. Okay. Write that down if you don't know it.
Yes.
Write it down. All right. How about this one? Let's do another one on this, because I tell you what, test questions like this. The nurse assesses a postpartum client and notes uterine atony. So which action should the nurse perform first? Oh, I know you know that
one. Number 4.
Fundal massage.
That's right. All right, you got it. Okay, let's talk about hematomas. Hematomas are not pretty, okay? They're a collection of blood, right? And when it's inside the vagina or the vulva, okay, that's painful. Because anything on a woman in that area, the genitalia area, is very painful. I'm going to tell you. Okay. Now, what you're going to see is she's going to be saying, I'm in a lot of pain. And when you look at it, it has like a bluish or purplish mass. And I'm going to write this down, is unrelenting pain. Okay. It's very painful. I gave my patient like a Percocet, and I thought, well, that should help her. Nah, she was still in pain. So, it's hard. It's hard. Okay. And she maybe got a hematoma because she had a hard birth. She had a trauma during the birth process. Maybe they did forceps. And that skin is so tender and friable down there that basically that could happen. Okay. So let's see here. Let me move this out of the way here. Okay. What is the nursing action that's appropriate in the care of a postpartum patient to prevent, now think about it, fundal displacement?
2.
Yeah, ask the client to avoid, yes.
Yeah. You got it. Good. When the bladder is full, it pushes that uterus up and over to the side. Now, those are good. That's another one. That's a good question. Okay, so we're moving right along. We're going to talk about subinvolution. So we know what involution is, right? What is involution? You tell me.
The uterus returning to its normal state.
That's involution. What is subinvolution?
Or not
It
return.
fails to return.
Yeah, slow return. Good,
Oh,
good,
so-
good. Yeah, good, good. So you have to, you have to bring her in. Sometimes they go home and the uterus is not contracting, or she has her lochia. Remember we talked about this, lochia rubra. She goes to lochia serosa, goes to lochia alba. But when she goes home, if it goes what? If it reverts back, she now should be maybe day 10, and she should be what? Lochia serosa. But if she starts bleeding again and changes to lochia rubra, what's causing that? That's, her uterus is not going down normally. So what's causing that?
Actually,
The retained placental fragments?
Yeah, you got it. You got it. Yeah. Retained placenta fragments makes her bleed. Okay. That's why you have to be very careful when you discharge somebody. Okay. There'd be a question about maybe a thrombotic embolotic disorder, clotting. You can have that venous stasis during pregnancy where the blood just pools down in the lower of the knee of the legs. They can have pressure behind their knees. All right, especially the days that we used to put these patients up in stirrups, and the whole pushing time. She could be up in stirrups for 2 hours. Those were days that we did those kind of stuff. Okay, and we know that fibrinogen levels increase during pregnancy. So what do we look for on the postpartum floor? What's that sign called? It starts with an H.
Homan sign.
Homan sign. Homan sign. You got it. Homan sign. Okay. All righty. So classic symptoms of a DVT do include muscle pain. Okay, and a positive Homan sign, like we just said, and swelling of the affected limb. All right. Is that true or false?
true.
True.
True. Good.
Professor,
All right.
I had a question on Homan sign.
Oh, sure.
I was listening to something. I can't even remember if it was one of the other lectures, but I noted that it isn't always reliable.
No, it's not. But I tell you what, it can happen. And when my patient calls me and tells me, nurse, I have pain in my leg, right around my calf. Can you come down and look at it? I said, sure, because I'm thinking it could be. It could be. So I go down there, and the calf is warm to touch, and she's got pain, in the muscle. And I kind of dorsal flex her foot back. And when I do that, she goes, oh, okay. All right. So that's pretty significant. So I called the doctor and I said, well, I did my assessment and she could have an emboli. So he says, you know what? Do a venous Doppler, Irene. I said, okay, gotcha. So I want an order for that. And I'm going to tell you, 9 out of 10 times, thank God, I was blessed on that. They were negative. Okay. But can I just say, oh, you'll be fine. Oh, you'll be fine. No. So as a nurse, I'm going to dive in a little bit further and find out. And then if it's negative, what can I do to prevent anything from forming?
Have her ambulate.
Yeah, ambulation is your best thing. And not only in a postpartum patient, but also for all your surgery patients. We get them up very early. We even get post-op cardiac patients now up. We used to let them, let them lay in bed. We don't let anybody lay in bed anymore. That's why they don't like to come to the hospital.
Hotel.
We get them up and out of there. Okay, let's have another question. So your patient is 5 weeks post-vaginal delivery. So during the doctor visit, the patient states that she notices foul-smelling drainage. She's got pelvic discomfort, and she's been running a slight fever. So the nurse relays these findings to which of the following? What does this lady have?
Two.
Yes, 2. Endometritis. Did everybody see that? Okay. Okay, yeah, because you're talking about foul smelling drainage, so something's coming out of her body that's not right. It's an
Infection.
infection, right?
Yes.
Okay. And another clue is pelvic discomfort. So
Yeah.
couldn't be mastitis, because what's mastitis?
Inflammation of the
the
breast
breast.
tissues.
Right, right. And it's not involution, because we already discussed involution, right? Okay. And a urinary tract infection. Now, some students like that answer, but she's got foul smelling drainage, okay? And it's coming out of her vagina, all right? So that wouldn't be a urinary tract infection. All
Yeah.
right. No. All right. So let's go on. We're just doing great here. Remember something, you might have a question on this, but also what standard precautions, proper hand hygiene is the primary method to what to avoid the spread of any kind of infection. I think you all know that, correct?
Yes.
So that would be a given question if it was on there. All right. That would be nice, wouldn't it? 2 points. All right. All right, so let's see here. Well, this is just your nursing care. This is just to prevent infection from occurring. So I'm going to use and teach good hand hygienic measures. And you might say, that's a given, professor. Yeah, I know, but you got to teach it. You know, people are not the best at this, all right, honestly. And then get your rest, nutrition, all right. And then, and if she has an episiotomy, what kind of diet would she have for an episiotomy?
High fiber.
Fruits and vegetables and fibers, yes.
Yeah, high fiber vegetables, water.
Oh,
Keep it
yeah.
all moving, because with episiotomy, right, we don't want her to get
Constipated.
constipated.
Yeah.
Right. Good. All right. And then teach her how to use, peri pads. Okay. Some women don't, especially our young kids. And then what are we going to do? How to do peri care. Again, when you have an episiotomy, you don't want to get infection there. That's the whole thing. No infection. So we're going to talk about mastitis. All righty. We already discussed a little bit. It's infection of the breast. All right. And I'm going to show you a picture, because this is what picture to me is 1,000 words. All right.
Ooh, that's painful.
Ah, yes, she got it. It is very painful. All right, it's swollen. There's a lot of edema. Okay, so you see that. You think she wants to breastfeed?
No, she'd be afraid for the baby to touch her breasts.
Right, and it hurts. Yeah, and sometimes it goes under the breast itself. The tissue, the breast, and then under here is called the tail of Spence, and that can get inflamed also. So I had patients walk into the clinic with their arms up like this, okay, because they couldn't put their arm down. All right, it's so painful. Now, if she doesn't have purulent drainage, which is what pussy drainage, right? Then she can still feed. But do you think they feed on this breast? No, but what can she do to relieve some of that discomfort? Well, first of all, go ahead.
Use warm water to dilate the blood vessels.
Yeah.
In the
Yeah.
bath, yes.
Shower.
Yeah.
In the shower, yes.
In the shower. Okay, maybe put some cabbage leaves on it, right? That would help. How about if she needs an antibiotic because she's got an infection? You usually give antibiotics and usually give a pain pill. I try to keep them, trying to empty the breast, all right? But a lot of people don't want to do that. Once they get this, they go, I'm done, all right? But we can encourage them to keep feeding. She can feed off the other breast and just express this one if she wants to keep breastfeeding, okay? Now, say this lady says, that's it. Do we support them on that decision?
You can only encourage her.
Right. Can't make anybody do anything, right? So just encourage. Okay. All righty. So again, which intervention should a nurse give to a patient to prevent? Now, this one says to prevent mastitis, and I'm going to promote the flow of the breast milk. I think, Pauline, you said it.
Yeah, take a warm shower before breastfeeding.
I had patients that said, oh, hold on here. I had patients that said, nurse, I have a little bit of a screwdriver. She drinks a little bit before she breastfeeds because it relaxes her. Have you heard anybody tell you that? Sometimes they just want to relax before the breastfeeding. Okay, that's not on the test though. So, a woman develops mastitis in the postpartum period. Okay, poor little thing. And she states, "I am so sad. I had to stop breastfeeding my baby." Oh, here it is. The nurse responds.
Number 4.
Yeah, number 4. You got it. Okay, good. And those are good questions. All right, let's move on to this chapter. So mood disorders. So what do I mean when I say a mood disorder?
I would say something that you would, I'm not going to read that. I would just say something that's not within what you would consider to be the norm.
Yeah. So in postpartum, when we talk about postpartum patient, what's the most common mood disorder?
Baby blues.
Baby blues, yes.
Yeah, the baby blues, yeah. And that she's what? She's kind of feeling down, right? Sad, all right? What do you think causes baby blues?
I would think it's an adjustment, or it could be hormonal.
Exactly, hormonal, or just an adjustment to this, what?
New life.
Yeah, it's a new life. It is very much so. Good, you got it. Okay. Now, if she has a little more sadness, more deeper sadness, what's that called?
Postpartum depression.
Yeah, depression, right? She it's greater than baby blues. The baby blues last about 2 weeks. Okay, give it 2 weeks. Then they come out of it. Usually the baby blues, they're just overwhelmed and fatigued. They don't take a shower, they have no support, and if it doesn't get taken care of, then it can get a little deeper. So then it goes on, and then she can get more depressed. Now she doesn't feel, she's not suicidal or infanticide. No, she's just very depressed, but she needs some help. Okay. So, and that can last, they can have this postpartum depression even a year after the baby's born. All right. So they may need maybe some antidepressants. They may need some psychotherapy. They may need to talk to someone. Okay. Now, when I start hearing voices, I'm going now deeper, right? Into this black hole, we call it. Which one is that?
Postpartum psychosis.
Psychosis.
Yes, psychosis. They hear voices. So, you study psych. It's like schizophrenia, they hear the voices. And there has been cases where there has been infanticide and suicide. Okay. And so you might have, I think Heskey likes to touch on that kind of question. All righty. So we just talked about the baby blues, so I'm going to skip over that. And I love cartoons. I'm that kind of person. So it says, "Hey, this is life. This is Mr. Life here." Yeah. He looks like he's serious, and he says, "I got a lot of things to do." And the poor woman, she's so exhausted and fatigued. She says, "I did things yesterday. When will things be done?" See, that's how you feel, when you get overwhelmed. And that can happen easily. Okay. Now the depression, like I said, is more serious than blues. And it does show his ugly face around 4 weeks after delivery. So you have at least 2 weeks or more with the baby blues, and then it just kind of evolves into this depression. And what happens, that mom, she doesn't feel like she's gonna calm the baby, but she's just not into it. You know what I mean? She doesn't listen to her baby's cues, which could be crying, so she needs some help. All right. And so she's not bonding with this baby like she should. All righty. So if I ask you a question, postpartum depression is an expected reaction following childbirth. What would you say?
False.
False. Good. See, wasn't that a little tricky question? Yeah. Okay. Simple question, but a little tricky. All right. So this is what postpartum psychosis can look like. It's very dark. She can't see, what's around her per se. She's not in life, put it that way. And so things are very dark, and hearing voices, not a good place for any woman to be. And so you have to be careful when you're assessing a person. You want to see their history. That very beginning, when we talked about all the way in the beginning, like when she comes in for her prenatal care, she could give you, say, I have a diagnosis, I have bipolar disorder. That is in itself is a red flag, because these ladies cannot, after they deliver, could have episodes of what we call mania. So we want to make sure that if she is bipolar, that we watch her a little closer, okay? Because they just have these deep feelings of worthlessness, and they don't sleep right, they don't eat right, they have, like I said, they have delusions, okay? And so you got to be so carefully with this, because it can happen. They can go into this very deep depressive state, and unfortunately it does happen. Okay, so we talked about this already. I'll let you be. Okay, so that was the complications after she gives birth. Okay, the big one, of course, is hemorrhage. Now, if I was to ask you, how many mLs of blood does it take to be considered a hemorrhage after a vaginal delivery?
More than 500.
500, 500. That's a lot of blood. If you take an IV bag, has 1,000 mLs, right?
Yes.
Think about it. Okay. Now, what about a C-section? How many mLs is considered hemorrhage after a cesarean?
Over 1,000 milliliters.
About 1,000, yeah, and greater than 1,000 and greater. And again, I got the picture of an IV bag. All right, not a good thing, right? All right, not good. So hemorrhage, and I'm going to tell you, you go back in history and you study a little bit about childbirth, and you can see how many women, unfortunately, lost their lives because they didn't know to massage the uterus. Okay, all right, we're going to move on. So we're going to talk about the term newborn, because I believe that's chapter 12. Yes, and that's going to be on your test. So we talked about in my lectures, I talked about reflexes. Some reflexes are an indication of what system in the baby? The nervous system. Okay. All right. So that's why when we talked about preterm babies, all right, we talked about they didn't have some of those reflexes. They didn't have a gag reflex, or very little. They don't have a suction reflex, okay? So they have very little maybe, but they're preterms. But term babies, when they're born, they should have intact nervous system. I want them to. And so we have blinking, which, it protects them. And then sneezing, they get the fluid out, gagging, okay, sucking, and grasping. Okay. They cry, they swallow, and swallowing, we have to watch them take their first feed, okay? Because, and in the labor room, we do watch them for that first feed. That's why I put the baby to breast, and I want to see how that baby is able to suck and swallow. Okay. All right. So, all right. Pauline, did you have a question?
It was a while back. The cabbage leaf was fascinating. I was wondering who came up with that.
Oh, that's been an old-timey one. And I think it's in your book too. Like, and when I read it, yeah, but you know what? It works.
Wonderful.
Yeah. I had I'm going to tell you a true story. I worked as a nurse on postpartum for a long time, and I had a patient that was badly engorged, and she was very upset before she left. So what I did on the way going to work, I went to the store and picked up some cabbage leaves and brought it with me. And sure enough, I put them in the refrigerator and it worked.
Oh, that's really lovely.
With nurses, you're going to find yourself when you're working with patients, you do a lot of different.
Yes.
Yeah, because you know, as nurses, we don't want to see anybody in pain. No, that's not our jobs to see them in pain. Our job is to what? Relieve them. All right. So here are some more reflexes about the nervous system in the newborn. The moral reflex or the startle. Okay. Remember, he puts his hands up in the air. Ah! And see my fingers? They go into like a C formation. All right. And so that's what they do. I know if the crib touches something and they get startled, then they put their hands up and they go, oh, and then I go, oh, nervous system's intact. All right. Rooting. Rooting is a very important one because it's about food. It's about what? You touch the cheek and the infant goes toward the source of the food. Okay. Babies need to eat. Okay. Now, the one I'm going to talk about is dancing. And that just makes as a baby touches a cold surface, he has a reflex to come up. You know, you have all these reflexes, but we don't think about it. But I know when you got a reflex when you have a hot oven.
Yes.
And maybe you have a hole in your mitt. That happened to me just the other day. There was a hole in the mitt. I guess a mouse got in my drawer or something and chewed up a hole and I didn't know about it. And so I used it. I didn't look at it. I was hurrying. And so I put the mitt on to take out the tray out of the hot oven. I tell you, my reflexes jumped real quick because my finger felt the heat. Okay. And so I thought when I did that, I thought, oh, these babies with the reflexes. All right. Now, okay. Yeah. Choo. All right. Thank God we have reflexes. All right. So now the next one I want to make sure that you understand and know about is called Babinski. Write that down. Babinski. So Babinski is one that you take your finger and you just go around, you stroke the sole of the foot. Okay. Okay. And he goes what? Boom, right? His little toes flare out. And so he feels it. That's good Rubinski. Now you might see that one again. So write that down and know that Babinski reflex. All righty, let's go on. Babies have the hardest job when they're born. They have to breathe. Now we take it for granted because we just breathe in and out. But babies in utero, they don't start to their lungs don't start to really move in and out until about 37 weeks gestation. So at birth, all of a sudden now that cord is clamped. And so they have to what? They got to take their first breath. So the most critical time in a baby's life is his first hour of life. I got to make sure he's sucking, that his reflexes are there. I got to make sure he's breathing. All right. So I observe, and his normal respirations should be between 30 to 60. Okay. There shouldn't be any nasal flaring. Nope. Shouldn't be any grunting or sternal retractions, because those are all signs of what? Those of respiratory distress. So I want to make sure my baby's breathing, right? So again, no 30 to 60 breaths per minute. Knows that he's got to move his lungs. His lungs got to what? Inflate. Okay. And make sure that he has a patent airway. I mean, these are things that you're going to do on every patient. If your patient has an obstruction in his airway, you gotta get it out of there, right? You gotta help him. That's part of your CPR, right? You're gonna die if you don't do it. Same thing with a baby. Now, babies are born with a lot of fluid. All right. So we got to help him get the fluid out. So we do suctioning, and we can use the wall suctioning right as he comes out, release it. And then we use what suction? We have a little blue bulb. Now, when I use the bulb suctioning, where do I put that bulb suction?
Towards the side. Yeah.
On the side of the mouth, right?
Yes, yeah, internally.
That's a good question, by the way. Don't put it in the middle because you make him gag.
Yeah, yes.
And whatever he's got in there, the mucus, fluid, if you make him gag, it can go down to his lung, and then you got more problems. All right.
Yeah.
So we want to make sure that what we do is correct. So we're going to put the bubble suction on the side of the mouth. Good, good, good. All right. What do we suction first, though?
The mouth.
The mouth. Okay, that's another good question. Mouth and then the nose. Okay. All right, and here's my little picture. All right, must be pretty important. She's got a picture up there. So this is exactly what you do. All right. Remember, patent airway. Okay. Now, what protein does this baby need to have circulating to inflate these lungs properly?
Surfactant.
Surfactant.
Surfactant, yes.
Okay. Yeah, that's always a good question.
Yes.
Yeah, I always put surfactant on there, believe me. All right, have a good understanding of APGAR, okay? Don't know that we're looking at, we have your little column 0, 1, and 2. Baby comes out and you're doing a 1-minute APGAR, and then you're gonna follow up with a 5-minute, okay? Because at 1 minute, he says what? He has to transition, right? And so that's a little hard time. So you want to make sure that he's able to. So his heart rate, you want to make sure that he's got a good heart rate. And if it's we want hopefully above 100. Am I right? Mm-hmm.
Is it 110 to 130?
His normal heart rate,
Could be.
even extra-uterine life, is 110 to 160. But for the APGARing,
160.
we give him credit, for the 100. Then respirations, breathing, all right, 30 to 60. Got to have some muscle tone. Now, a lot of newborns, and when they come out, they could be very flaccid. Maybe mom got a narcotic during transition. Oh, we don't do that. What do you have on hand to counteract that? To make sure he kind of moves. If he has no muscle tone, he kind of comes out, he's flaccid. Have Narcan. Okay. All right.
Okay, you're gonna relieve it. Okay.
Yeah, I gotcha. And then reflexes. All right. I tell you, when my babies come out, I dry them up really quick. All right. And I rub their backs. Okay. They get dried off real quick and rub their back. When I do that, I usually can stimulate them to have some muscle tone and their heart rate goes up. And they start crying, which I love, music to my ears. And their reflexes, they get kind of annoyed that they're being rubbed, but that's okay. And then their color. Now, a lot of babies come out and their color is off, okay? All right, so what's that called when their trunk of the body is pink, but the hands and the feet are blue?
Acrocyanosis.
Acrocyanosis, right? That's it can happen. And it can actually go on for 24 hours. But after that, they should be completely pink, okay? Because after 24 hours, if they're not looking, pinkish, there could be a problem with the heart, okay? So that's why we watch these things and we make sure that they get pink. And we do reassure parents. Sometimes, especially daddies, they go, oh, my baby, what happened to my baby? My baby's hands and feet are blue. That's okay, sir. Baby's just born. Sometimes it takes longer for that blood to start circulating, okay, in the body, all right, and get those peripherals pink. It takes time to get all that going. All righty, let's move on. We talked about APGAR. Just know that if you come up with a baby that's in respiratory distress, all right, such as having sternal retractions, we talked about, baby cyanotic, okay, you want to make sure that you notify someone very, very quickly, okay, so that they can intervene and find out what's going on with this baby. And remember, you don't want to ever make this baby cold. We call it cold stress. Keep that baby warm. That baby is having some respiratory distress as it is. You don't want to make it worse by making him cold. So remember, you want to keep these babies pretty warm, okay? Not super warm. You want to just be right. All right. Now, I would definitely know the signs and symptoms of fetal distress, okay? Respiratory distress syndrome. Remember, it was also called one time Highland membrane disease. All right. So you want to make sure. And, you know, baby, let's say nasal flaring, grunting, chest or sternal retractions. Okay. Baby's not pinking up, you know, maybe after 5 minutes, he still doesn't look right. You know, he doesn't have good color. You take that baby to the NICU and they'll do a 10-minute APGAR in there. Okay. All righty. So, and the reason why we do APGAR is just so that Dr. Virginia APGAR, very smart woman, she said the healthcare providers need to resuscitate quickly. Okay, there can be no delay, because when you do a delay, then this baby gets a lack of oxygen to the brain, and then you could have brain damage. So that's why they came up with this, so that we could jump in there. So like an APGAR, like a 7 to 10 is a good APGAR. You know, maybe just, you know, you don't want to cold stress them, so you want to make sure you get your warm blanket and, you know, rub them and dry them off. Remember, put a little cap on his head. Okay, so this is our slide just to show you the different pulses, and just to show you here on what you're looking at. So you got maybe you got a temperature, maybe if it's over 99.8, that's a little more hyperthermia. And so you may be overcooking them, okay? You can have problems too that way. Or if you don't have the radiant warmer ready to go when he's born and he gets a little cool, below 97.1 could be very serious with this baby. A pulse rate. Stefania, you said the right too. This is just on his vital signs, where APGAR scores got a little bit different. Pulse greater than 160 is tachycardia, okay? And this is the same that it was in utero. Same thing. This is kind of easy to remember. And then less than 110 would be bradycardia. And then respirations greater than 60 is tachypnea. They always have a question on tachypnea, okay? They have a scenario and they might give you some abnormal lab, especially HESI, abnormal lab, and you have to know that that's a sign of respiratory distress. All right. Noisy respirations, that's like grunting. Okay, grunting, never good, guys. And then nasal flaring or chest retraction, like I said. All right. All right, and we'll move on. Remember, another problem with a newborn is maintaining body temperature. Okay. Now, some people like to put on test questions about radiation. You know, they'll ask you what the heat loss is by conduction. And, you know, you may have a choice. Okay. So, you know, remember, babies lose heat very, very easily, like I said. And so if they lose it by convection, you want to what? Prevent a draft. All right. Put down prevent draft. Okay. And then put down they lose heat by, it's called convection. All right. Now, another one is don't place this baby on a cold surface. Oh, okay. Because conduction, that means the baby is losing heat through conduction. For example, putting a baby on a cold scale. No, no, no. That will stress him out. So I put that little tissue paper down. It doesn't weigh anything, but it helps. Okay, he doesn't lose heat. Again, I'm thinking, I don't want to cold stress my baby. And then don't put him by a window. Okay, I don't like babies by windows anyway, but they do lose heat through a conduction pattern as called radiation. All right, so you want to make sure. Now, I have over the years seen questions about when a nurse is doing her assessment on a newborn. Okay, so you have like an open crib and you come in to do an assessment. You only want to expose the area that you're looking at and that you're assessing, maybe the heart rate, or maybe his legs, or you're looking at his arms. You just want to take the extremity or area that you're looking at and expose it. Okay, you don't just take all the clothes off and take all the blankets off, okay, because you're going to cold stress him out. All right, so it'd be like a shock. So you just want to, you know, just expose the area that you're looking at. All right. And then another way they lose heat is by evaporation. Okay, the infants, you keep the infant dry. And so that's why when that baby comes out, I dry him off really, 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 really quick. Okay. All right. So that's how they lose body heat. All right. Let's see if I have anything here. Now write this down. Cold stress. I've been saying that quite a bit this morning. So cold stress can lead, is never good. Baby's hypothermia. It leads to hypoglycemia. Write that down because you're going to see this one again. So cold stress leads to hypoglycemia, which is low blood sugar. Okay. And that leads to what? Respiratory distress. Okay. Now that can lead to respiratory distress. All righty. Let's go on here. How about we look at skin? Because there's quite a bit on these tests on the skin. Yeah, what is Langugo? I love that term. Lanugo. Come on.
Next is it's not a little white cheese in it. It's like some little hairs.
Okay, I just heard the word here. Little tiny hairs. Okay, good. Now at term, because we're talking about a term baby, at term, baby has a little bit, because he's a term baby now, so he has a little bit. But when they're pretermers, they are born, the hair is still there because they're too early. Okay, so Langugo. And they usually have on a term baby, they usually have a little hairs on their little shoulders, okay, and maybe their ears. What is Vernix caseosa?
That's the cheese
like covering, protect them in amniotic fluid.
Okay, so it's what? What does it look like? Is it white?
Yes, white and cheese-like.
Yeah, it's like white and thick, like a cheese-like. Okay, that's what they're supposed to describe it as. Okay, and it protects them while they're in utero. Right. All right. Let's talk about jaundice. Okay. Tell me about jaundice.
Well, it's abnormal. It manifests as yellow, but it's because of okay, if their head is squeezed during the molding, or then the hematoma blood can go into the stream of the bilirubin, and then that can produce jaundice in the liver.
Yeah, it can happen with a subtle hematoma, but regular. Let's start back and talk about physiological jaundice. Okay, that usually occurs within maybe 3 days at the birth, 2 to 3 days at the birth, and it's just like a little yellowish tinge to the skin. Okay, now what happens is that his liver is immature, and so sometimes you have this rapid destruction of the SS, too much RBCs, red blood cells, okay? And so then, therefore, you have increased what? A bile that's in the baby's blood system, all right? And that's what causes that yellow skin. Now, physiological jaundice, you do see a lot of babies with it, okay? And we put them under, what kind of therapy can you put a baby or do for a baby to help him get rid of this jaundice?
Phototherapy.
Phototherapy. Yeah. Phototherapy has those beautiful Billy lights. They're very bright, and they will go ahead and break down that bile, and then he excretes it. Now, he excretes it through what? Urine and through feces.
And feces.
Right. That's why these babies sometimes, most of the time, they're fed a little bit sooner. They're given more fluids. That's a good test question. They're given more fluids in order to him for pee or poop more. Okay. All right. Yeah.
The babies that didn't have the light in the days past and they used the sun, was it just as effective?
Yeah, they use the sun. Now, if you're born up north, that sunshine during the winter months is not as great as if you were down in the southern part of the United States, such as Florida. But yes, taking them out. That's why it is important to get these babies out. Back in the 40s and 50s, that's what they did. They used to take the baby for a walk. And they have them in those carriages, right? And they have the sun coming on them. and that's what they were doing. They were breaking down that SS mount of bilirubin, all right? Because we don't want them to get hyperbilirubinemia, all right? We don't want that to happen because that can cause brain damage. And that's called a condition called kernicterus. So we don't want that to happen. So we want to hop on it. So that's why you take your finger, guys, and over a bony prominence, you put a little pressure on that area, and then you let your finger up. And what you see is you'll see the yellow. Okay. And that's how we tested for that physiological jaundice. Now, if baby has jaundice and occurs in the first 24 hours of life, what is that called?
Mm.
Is it pathophysiology? Pathophysiology?
It's pathological jaundice. Yeah, you got it.
That's
never good. That's never good. Okay, because that means that there's something that liver is, even though we know it's immature at birth, okay,
Yes.
it's not normal. So we have to hop on that baby, and they'll do a lot more blood tests on the baby, especially like liver enzymes. They'll probably look at that and do ultrasound of the liver. All right. I tell you, when these babies are born and they're breathing and they're crying, that first cry, and they got acrocyanosis, they got a nice pink trunk, okay, or that now they're 5 minutes of birth and they got their hands more pinkish and they're moving around. That is like the best thing you could ever see, because there's so many things that could go wrong. You know what I mean? So when you see these babies and they come out and they're doing so good, that's my little miracle. It makes me very happy. How to share that. So let's talk again about some skin conditions, because I know that they like skin conditions. Okay. So if I have a baby that has these little white pinpoint pimples on his, like usually you can see it on the nose and the cheeks. What's that called?
Milia.
Milia, right. Everybody got that down?
Yes,
all right.
Milia.
All right, so we talked about the fine hairs on the body of an infant. That's called langugo, right? We talked about that already. The other one we haven't talked about is the Mongolian spots, all right? Those are the bluish discolorations of the skin, and they're usually found on the gluteal areas of a baby and the sacral areas, okay? Now, there is no magic cream for these Mongolian spots, but they do have a tendency to fade, but they never go away, all right? And your biggest problem with these kind of babies, and it can happen to, is when you have them come into the ER and you're trying to cipher out, you see a newborn, you're trying to cipher out, is this baby abused or does this baby have Mongolian spots? So that's the biggest problem I find in the ER when you have a baby that comes in, you see it. But he does it because they look like bruises. And in your book, there's a good picture of them. Now, we talked about the Vernix caseosa, okay? And the other one is port, P-O-R-T, wine. And that's also known as the Nevi flame EUS. What it is, it has a collection of capillaries in the skin, all right? Now, the ones that Hesse likes, I know that maybe you'll see again next week, is Manila, Langugo, Mongolian spots, Vernix caseosa. Okay, those are the most popular ones. All righty. Let's talk a little bit about this normal newborn GI system. All right. Okay. So what's the first stool that the baby puts out? What's that called?
Meconium.
You're right. Okay. So what you have a mixture of amniotic fluid and intestinal glandular secretions. I'm going to tell you guys, it's thick. All right. It's very thick. And I think I got a picture here. There we go. And you can see here, look at my pointer, that thick. To me, it looks like tar. Okay. and it's thick like tar. Now just think. This baby passed meconium in utero, and he's laying in this thick tar looking substance, even though he's in amniotic fluid. Like granted, there's a lot of other fluid in there. It's still very heavy at birth when he does when he's born. And this is why we do that heavy suctioning with the wall suctioning. We get in there, and as the head emerges, we suction. Okay. And that's why we don't stimulate this baby to breathe right away. Is because we want to get it over to radium warmer so that respiratory therapy in the NICU nurse will go ahead and do more deep suctioning to get that meconium out. They do 2 passes with the wall suctioning because this kind of suctioning can make his heart rate go down. Okay, so you don't want to stress this baby out anymore, but you do want to get this nasty looking substance out of there. Okay, because the complication that you want to avoid is meconium aspiration syndrome. All right, now you can see here the difference in the meconium after breastfeeding. It looks better, don't it? Okay, remember, breast is the best. And then here you got the first transitional breastfeeding. That means it's going now, it's in the process of changing. And then you have your second transitional, okay, in more yellow. So a good test question could be that the mother is concerned because she tells the nurse that the baby's having yellow stools. Probably in the beginning of the scenarios tells you that she's breastfeeding. Okay, is that normal?
Yes.
Yes. So your reaction to the patient would say, yes, that is normal and your baby's okay. You know, that happens. Baby's just passing his stool. And as things go on, this is when you go from here, you go, here's your breastfeeding stool. And I tell you, it looks a little grainy. If anybody ever breastfed, it looks a little grainy. And it has a sweeter smell to it other than regular stool. Okay. All right, let's go on. Let's see here. So we'll go back here. So we got the meconium we talked about, and it's usually passed on 8 to 24 hours after birth. All right. All right, we'll jump here. Oh, here's that question, that I just asked you. So it is a normal finding. All righty. Okay, so remember, we want to prevent infection. So good hand washing, because newborns are born with passive immunity and from their moms, and usually about 1 month. Some books say 3 up to 3, but just know they do have some immunity from mom. Okay, so they can't fight off heavy infections, because their immune system is immature. Remember, this is a little guy come out and he's got everything he needs to live, to survive, right? But he's going to grow, all right? And even his immune system will get more mature. You want to make sure that the umbilical cord is kept clean, because that's a primary site of infection, all right? So just clean it, and you clean it from the base and coming up. All right, because you want to break whatever dirt or whatever bacteria is around the hub of the umbilical cord. You want that to come up. Okay. And when you're diapering a baby, you make sure that the diaper goes what? Underneath that cord, okay? You don't put the diaper over the cord. Now that's good on teaching your discharge teaching for a newborn, is to go over that with mom, because a lot of moms don't understand that they should fold that diaper underneath the cord until it falls off. All righty. Let's go on. We're going to go to chapter 13. We're just moving right along here, and then we'll do some questions. All right, so this is my pretermers, our special little babies. Yep, you have a question?
Sorry, go ahead.
Oh, that's okay. I thought maybe you had a question. All right, so we went over term babies. So what do you think about preterm babies? What do you think their problems are?
Respiratory.
Yeah, respiratory. What are they deficient in? What don't they have enough of? Come on, I know you know it.
Estrogen.
It starts with an S.
Surfactant, yeah.
Surfactant. Okay, good. All right, good. All right. Now, ACOG came out with this gestational age. Now, a good question could be, what, a baby born between 42 weeks, 0 days and beyond, what is that called? And you would answer?
Post-term.
Post-term, right. If
Okay.
the question asks you, a baby born between 41 weeks and 0 days to 41 weeks and 6 days, what would you answer?
Late term.
Late term. A baby born between 39 weeks and 40 weeks and 6 days, you would answer?
Full
Full
term.
term.
Full term. Okay. A baby born between 37 weeks and 38 weeks and 6 days, you would answer?
Early term.
Early term. And a baby born less than 37 weeks, you would answer?
Preemie.
Preemie, yes. So you see how those questions could be asked? And then you have to sit there and go, okay, I know she went over that.
Preterm, wow.
That's why I did it with a little jingle jangle. Oh, look at here.
Yeah.
Which classification will the nurse assign an infant born after 42 weeks? Oh, you know this one.
Post-term.
You got it. Okay, good. All right. We kind of went over this already when I was talking about RDS, but again, it is big with preemies. It's just because their lungs are immature, guys, so they have decreased gas exchange. And surfactant, remember that surfactant I told you was a fatty protein. What it has lecithin, and that is necessary for the lungs to absorb oxygen. All right, makes the lungs be able to move in and out. Okay, and breathe. All right, and usually this surfactant, it starts in the fetal development weeks, about 25 weeks. So if a baby's born, say, at 27 weeks gestation, all right, he doesn't have a lot in there. So that's why you have to be, as a nurse, you have to know that, so that you can anticipate this preemie is going to have some difficulty breathing on his own after birth. All right. So that's why we have to know these information. So here's a brain teaser. Excuse me. Which complication will the nurse assess in a premature infant who is deficient in surfactant?
D.
See how that question could be asked? Because you know it couldn't be deficient in surfactant. Well, no, cold stress. No, that's because the baby's cold. Hypothermia. So I'm not going to put that one. Because they're asking again. I go back to the question and I read the question again. Which complication would be in a premature infant who doesn't have enough surfactant? See how I changed that? And I go, oh, that's what they're asking me. It has to do with respiratory. And so then you choose respiratory distress. Low blood sugar can happen based if the baby is cold stress, right? We talked about that. And then hyperbilirubinemia would be too much circulating bilirubin through his system. Nah, that's not deficient in surfactant. So you see how I took that apart and you come up with the right answer. All right. Okay. So what's your nursing care of an infant with RDS? You tell me so that I can drink a little bit of my coffee. Come on. And what's the first one? Come on. Monitor vital signs.
Cluster care.
Yeah, monitor the vital signs. Okay. What is cluster care?
Making sure everything's done like at once, so that way you don't stress the baby out.
Exactly. And the reason is you want to put this down. You want to help conserve energy.
Energy, yes.
Yeah. Those little guys, if you touch them, I'm going to be honest, when you touch them, they just get really like, who's that? What are they doing? Okay. They start moving all around. Believe me, they do. And so when they do that though, guess what? They're using energy.
Energy, yes.
And their blood sugars go down. And I don't want that to happen. Then I got more problems. So that's why I get all my stuff together. And so I don't have to go in and out of the room. Okay. Because every time you do that, you close the little incubator up. And then he starts to rest a little bit. Okay. Think about it. Just think about it. And then you leave and then you come back again. And he goes, oh, she's back. And they get all hyper again. Okay. And that's true. All right. Even when you do, what about on a med-surg floor? When you're going to do, say, a wound care, don't you get all your stuff together so that, you don't start wound care and then say, oh, wait a minute, I have to go out and get the hydrogen peroxide. Oh, I have to go out and get the dressing. Oh, I have to go out and get the tape. No, you don't do that. You do everything. You get all your supplies so that you can get it done in one shot. That's what I'm getting at. And so that's what you have to do. Okay. All right. And then of course, RDS is pretty serious respiratory distress. So make sure you have an IV going, and got to make sure when you have an IV in a baby, it's on a pump for sure. And you want to make sure that you don't overhydrate, because you overhydrate. What's a sign of overhydration in a baby? What happens to his little fontanelle?
Bulging fontanelle.
It bulges, right? Yeah, overhydration. Now, when a baby's fontanelle goes down, like we call it sunken fontanelle, what does that symbolize? What's that?
Dehydration.
Dehydration. Good. Okay, good. All right. Why do I worry about putting a pulse oximetry on a baby?
I'm thinking that to squeeze them.
Want to make sure it doesn't go below 92.
Yeah. Oh my goodness.
Okay.
Everybody give her a clap. Yes.
Yeah, I want to monitor. Okay. I misunderstood the question.
That's okay. What you want to make sure, you know what, Pauline, you have to make sure that you don't give this baby too much oxygen. And you're probably thinking too much. Yes.
Oxygen toxicity. Yeah, I saw that.
Right. Yeah, you don't want to give this baby a lot. And like Safania said, 92% or above is sufficient. Years ago, we used to give them so much oxygen. And then you damage the retinas in the baby's eyes. So we got away from that. Put the pulse oximeter. Where do we put that pulse oximeter on?
Honestly, I'm thinking toes.
Yeah, well, you close foot. Okay, it's on the foot. Yeah, yeah, toes, foot. That's good. The toes are connected to the foot. The foot's connected to the toes. Yeah. Okay, so we got this toxic response, and that's a big word, but you may see this again. So I want you to write this word down. Bronchopulmonary dysplasia. Boy, that's a mouthful.
Oh yeah, that's too much oxygen. Okay.
Too much oxygen. It kind of burns those lungs. Wow. So you don't want that. It's a toxic response to oxygen therapy.
Yeah.
Yeah. Okay. So if you talk to someone tonight, Pauline, tonight, when you're talking to your friends, say, you know what? I learned a new word, bronchopulmonary
dysphagia.
And they're going to say, man, you're learning something in maternity. Okay.
All right. Professor, we are learning a lot in maternity.
So again, when you have too much of thickening of the lungs and of the tissues, the membranes, you can interfere with normal ventilation. Not a good thing for these guys. You're trying to help them, not hurt them. So that's why, we have to be very careful. We put the pulse oximeter on, we're monitoring that, and we're making sure that we've got a range of 92% or above, and we're good. That's it. Okay, so you got that down packed. So everybody gets 100 on this one. All right. And this is what we just said. All righty. So with my brain teaser, I know you got this now. The nurse is assessing the pulse oximetry of a preterm infant. Which of the following indicates a normal reading?
Oxygen saturation level of 92 or greater.
Right, you got it. Now you got it. You got it. So my nursing tip is I'm always looking for signs and symptoms of cold stressing. And when I see a baby that has a decreased skin temperature, okay, not a good sign. Okay, hypothermia. When I have an increased respiratory rate, so that means greater than 60, and he's breathing so fast, actually loses his breath. So he has these times of apnea. Okay, poor little guy, he's working hard. And then you have his heart rate will go down because his respiratory rate is so fast, and so his heart rate will go down. He's working hard to breathe. Okay, he's cold. Just think if you went out in a snowstorm and you only had your shirt on, would you be cold? Would you be, would your skin start to show funny, coloration of your skin? Yeah.
Hypothermia,
That's
yes.
called modeling of the skin.
Modeling, yeah. Oh, wow.
That's abnormal. It doesn't look right.
No.
Oh, and I'm cold. But, as a baby, I can't shiver. It's not, I'm just sitting there going, oh, okay, I'm cold. So I'm going to try to breathe really, really, really fast. And so then I lose my breath, and my temperature I'm cold. So it's going to be very low, and I get tired. So I'm going to be lethargic. I'm going to say, okay, I'm getting tired. And he's using up a lot of his blood sugar. His blood sugar is going to go down. All right. So if I was to ask you this question now, which of the assessment findings will the nurse associate with cold stress in a preterm infant? Okay, so it's all that apply. Okay. A.
B.
No.
Tachypnea. Okay. Okay.
A,
Okay.
D.
C, and D.
So
D.
A, modeling of the skin.
C.
C, decreased skin temperature. And what else? And D, tachypnea, periods of apnea.
Apnea, yes.
Yeah, okay. Remember, I would have bradycardia, not tachycardia,
Okay.
bradycardia. And I wouldn't be excitable. I'd be so tired trying to, keep warm that I'd be lethargic. I'd be very tired. Okay. So this is a good, I would consider this a good all apply question. All righty, let's move on. We talked already a little bit about jaundice when we talked about a term baby. It's the same thing with a little preemie baby. This guy, his liver is really immature. Okay. So he can't get rid of the normal bile pigments that come from the normal postnatal destruction of RBCs. Okay. So he could, and two, his little skin and his whites of his eyes, they get a little yellow orange. Okay. Again, all due to immature liver. Okay. And when serum bilirubin levels get really high, so the higher, then the more pronounced jaundice. You would see more pronounced jaundice. And with that, you have more risk for neurological damage to the brain. All right. So do I want to jump on this? Yeah. And we do. These little guys usually end up in this kind of treatment. Let me make this a little bigger for you, because I love pictures. There's like 1,000 words here. So you see the ultraviolet light. He's in a warm incubator, okay, because we got him stripped down all the way down to his little diaper. And so, and we have a little patch on his eyes, as you can see. And he's got to keep those patches on to protect the eyes from the ultraviolet light. Now, we got him naked because those lights, we want to get the lights on his skin to break down that excess spot. That's what we're doing. Okay. And we don't want him to get brain damage or get a condition called kernicterus. We don't want that to happen. So we're going to work really hard. Now if mommy is breastfeeding, she can breastfeed him more if she needs to, okay? And more fluids is good for these babies, okay? So that they could pee more and poop more. Because when they pee and poop, they get rid of that belly ribbon, okay? So just think, here's my little picture. Okay, and I love to put this stocking over his little mask because these little guys, they're moving around. We don't drug or anything. They're moving around. So he's take his hands and he's gonna take his hands and try to get that mask off. And you're always putting it back on. So this works really well and keeps that mask on. Okay. Again, you want to always protect the eyes, and that's a really good question. All right. So we know what the goal of the phototherapy is, to break down the excess bilirubin that's circulating in the blood. Okay. And the nursing care, we just talked about that already. Got a little diaper on them, got them underneath the billy lights, you're keeping them warm in the incubator, and he's getting the amount of fluids he needs. And we're going to do a strict I&O on this baby. Okay, let's go here. So this is a slide that we're going to put everything together now. So this is your nursing goal for the preemie baby. I've got to improve his respirations, okay? Make sure he's got surfactant. Now you can give surfactant after they're born through called a surfactant elixir, which is a liquid form. And you can put it down the ET tube. It usually takes 72 hours for that to see improvement, but at least we can do that. So we gave mom, before this baby was born, we gave her 2 doses of betamethasone. You know that. That's a steroid to increase the surfactant production while in utero. Now he's born. So now we see that he's having a little tough time breathing. He'll go to the NICU. He'll have an ET tube, right? They'll tube him. And then they can give him more surfactant to help him breathe. Kind of nice. Now, another goal I would think too would be to maintain body heat. As we know, babies lose a lot of heat, and we got to make sure this baby stays warm. So what we're going to have ready is the radium warmer. Okay, the radium warmer, and you'll have that in the delivery room or in the operating room, wherever this baby's born. So when the baby comes out, we can maintain body heat. Now, another question could be, what could you put on the baby's chest to make sure that you don't overheat the baby? And that's that little skin probe, okay? And we attach that usually in the right upper quadrant, and we put that little probe on, and then we connect it to the radium warmer. And we can make sure that we don't overheat a baby, okay? We talked about conserving energy with the cluster care. Make sure baby doesn't get hypoglycemia by too much stimulation. These babies don't tolerate a lot of stimulation. And they have all these lights, in the NICUs, NICUs have gotten much better because they have realized that all these bells and whistles really, really affect these preemie babies. And then we make sure we got proper nutrition. Now, this kind of baby may have nutrition because he doesn't have the reflexes that he should have, like sucking and swallowing, because he's so immature that we may have to do what we call cavage feeder, okay? And then we talked about having IV and having it on a pump. So make sure that you don't overhydrate. That would by bulging fontanelles, or he's getting dehydrated. Okay, that's a good review, isn't it? And then, of course, skincare, just like any other adult, you're going to do skincare. And then you're going to document everything. Now, what about the parents? What do you think we have to do with parents? Well, just put yourself.
Educate the parents.
Yeah, just put yourself in that room with all these little babies, and they're all, trying to survive. And it's very emotional, very emotional. And so that's why I love my NICU nurses, because they are so good. They're right there for the parents. It's very emotional to see all that. But we do kangaroo care. We make sure that when these babies are stabilized, we can put the little preemie right to mom's chest. It's really cute, okay? And they do wonderful. Now we have to talk about the nutrition, because this is a really good question to see next week. It's called clavage feedings. Okay, so you may see little babies. If you went on YouTube, there's a whole bunch of little videos on there about preemies. Okay, you may see a little tube that's in their nose and it goes down to their stomachs, and that's called clavage feeding. Because remember, they don't know, they don't have the reflexes, like I said. So we want to make sure that we get them feedings. They need protein. So you get breast milk, or you can use the formula. Now, breast milk is thinner, so it's better for a preemie baby. So because formula is heavier, has more fat in it, so it's thicker. So that may cause that preemie to not be able to digest it as good as breast milk. And that's why we have milk banks, is for that very reason. So you want to make sure that your baby doesn't get, this is why you're making sure he's feeding. You want to make sure that you avoid hypoglycemia. You want to give enough fluids so that you keep that bilirubin under control. Otherwise, he would get hyperbilirubinemia. And you want to avoid dehydration. So that's why you want to make sure these babies get fed. Now, the main thing about clavage feedings, and you must write this down, is that when you're going to do the feeding, you always aspirate the contents first. I don't want to give baby more, like say more formula or more breast milk if he already has some residual still there. I can't give him more. So I aspirate. So everybody write that down. Aspirate the contents before giving the next feeding. If you get residual, if you get back the formula or the breast milk, say, then you don't do that feeding. You don't want to overfeed the baby. Okay? You got it? Yes. So you always want to aspirate before you give the feedings. Good. Okay.
So it's kind of like almost a regular feeding tube where you'll make sure you'll see if they have the residual. If so, put it back.
Exactly. Exactly. Okay. Exactly. Very good. 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 Love it. All right. So here's my little brain teaser. Which nursing action is most appropriate prior to starting clavage feeding on a premature infant? I know you know it.
D.
D.
D is in dog.
D is in dog.
Dog, yes.
Yeah.
But
You'll
Professor, I wanted to,
so
I wanted to know, when we're aspirating their, them to see like how much are we looking for with the infant?
Well, you only have his little stomachs, especially in the preemies, even smaller. But you have like, you can put in a regular term baby, you can put like 3 ounces. So if you're getting back, say, which is like 90 mLs?
90 mLs.
Okay, so if you're getting back, say, 45 mLs, that's way too much. Okay, that means he didn't digest anything. So you, based on that, like even 15, even 5, I say, So you write down, and then on your doctor's orders in the NICU, they'll have the parameters. If you get back 10 mLs, you hold the feeding for an hour and then reassess. And they'll have, if you get back 10, let me see, 20, they'll have the parameters as how long you're going to wait till you feed again, until you attempt again. Okay.
Gotcha. So on average, it could be like, well, pending the facility, but on average, like 5 to 10 mLs.
Right. That's a lot, that's a lot to get back, because that means that baby has not digested that formula. Okay. And preemie babies, they are very slow. So that's why you be very careful with preemie babies with clavage feedings.
Thank you.
You're welcome. Okay. So let's talk about a post-term baby. Okay, so we did our preemie. So that's chapter, let's see, chapter 13 was pre and post. So let's touch upon our post-term. All right. So a post-term baby, let's see, although they could be big babies, right? You'll just think 42 weeks and beyond. That's your post-term baby, right? Yeah. So what kind of problems do you think they could have?
Oh, the
Macro.
macrosomia.
Wouldn't it
Well,
be like macro baby?
yeah, they're big babies because they've just been in there kind of keep eating, right? And they go, I don't want to come out of here. All right. I got it made in here.
The placenta had
Calcification.
the placenta
Yes,
being
good.
used up already. Yes.
Yeah, good. The placenta gets old. Okay. It does
Older.
calcify. Yeah, yeah. So it doesn't give the nutrients, So babies can be asphyxiated at birth. The babies could have increased red blood cells at birth. That's called polycythemia. If
Okay.
they have that, then they are at a real risk for hyperbilirubinemia. You got me? So yeah. So these are things that can happen. What about passing meconium in utero? At 40 weeks, that's term. Okay, you're supposed to be like, okay, let's get out of here. But this guy is 42 weeks, so he's already had his meconium. All right. And so now, remember we talked about that. So he is a risk for meconium aspiration. Okay, because he had his first bowel movement inside, and he could be very sick after birth if he aspirates on that meconium. That's why we go the extra mile by suctioning, with wall suctioning. Okay, as soon as that head pops out, get in there, clean it out, and then we don't stimulate these kind of babies. They go to the radiant warmer and we suction deeper. Okay, because we don't want them to aspirate on meconium. When you have a baby that aspirates on meconium, they are very sick babies because meconium is so toxic. His stool is amniotic fluids, all kinds of, could have vernix in it, could have lingugo in it, the hairs, and that gets into the lungs. It burns their lungs. It damages their lung tissue. All right. Poor nutritional status. Okay, these are a big babies, so they're prone to, let's see, hypoglycemia, low blood sugar. So that's why you'll see a lot of questions with low blood sugar, okay? Because it's a big problem at birth, all right? So we want to make sure that we test for hypoglycemia. How about a difficult delivery? If you got a big baby, what could happen to mom?
She could hemorrhage.
Yeah, she could hemorrhage. Exactly, you could have postpartum hemorrhage. What about if she had forceps delivery?
Oh.
We talked about that about an hour ago.
Yes.
Remember we talked about what? Vulvar hematoma.
Yes.
Okay? Yeah. Moms can have a lot of problems, right? And babies, what about if the head comes out and now I'm experiencing shoulder dystocia?
Yes.
It'd be like a
What's one of the, I said this one of the,
synovial, I forget, but basically their shoulder, like they have to wind
dislocate.
up breaking,
Yeah, dislocate. So
You have to get this. Okay, so imagine you're in the delivery room, and imagine the head comes out, right? And the head looks like it's getting bigger. I've been there, and the doctor says, "Hey, Irene, I need some help. I can't get the shoulder. We got what we call shoulder dystocia. Okay, these big babies have wide shoulders. All right, so he cuts a 4th degree episiotomy. Think about it. 4th degree episiotomy. She's wide open peritoneum, and he says still not good enough. Put her legs all the way back to her ears. Now you got the picture. Now we're really trying to get everything to get that baby's head out, and so he says I had to break the clavicle. So now this poor macrosomic baby, because he grew too big, because he's post-term, he's 42 weeks and beyond, that now he's got a broken clavicle. Now, thank goodness, and that when you do that, you say, everybody touch your clavicle. and see, when you're in there and you just kind of press down and break that clavicle. Now, don't you all break clavicles, okay? But just think, all right? And then when you do that, the shoulder, see how my shoulder went down? It releases. And so then we can get that shoulder out. And the poor mom has a lot of damage to her perineum, because don't forget, we had a 4th degree that's all the way back to the anal sphincter. And that's a lot of sewing, because don't forget, you've got a lot of tissues to sew up, okay? And each layer has to get sewn individually. So we sew them up so that she'll have a decent scar, okay? We don't want her to have a big scar there. So yeah, difficult delivery, believe me. And I hope that you could visualize, as I was talking to you, be in that delivery room with that big baby. All right. And then you have some birth defects. You can have, I'm thinking of one right now, kind of a club foot, okay, where baby just runs out of room and his foot is what, bent over in a different position, and it's there for a long time, okay, big babies. And then, of course, neurologically, they could be affected, and you can have a baby with seizures. So post-term, okay, you'll be very careful, because you have to worry about the baby getting enough oxygen so that he doesn't have problems at birth. Okay? All right. Now let's move right on to chapter 14, and we're almost done. Okay? And I'm going to point out some highlights for you. And the couple of them okay, let's see here. So this is how you kind of categorize these congenital malformations. All right. So put down one, you put down, like, let's start with chromosome anomalies. Okay, write that title down on your piece of paper. And then we'll go back and fill it. The next one I want you to write down is injuries, perinatal injuries. And you have another one is inborn. That means they're born with it, errors of metabolism. And we're going to talk about those two. And then the last one we'll talk about is disorders of the blood, ABO incompatibility, erythroblastosis fetalis. Okay, so let's jump right in. So let's now write another topic, neural tube defects. Okay. Now remember, these things occur during the embryonic development. Okay. So embryonic development, remember, was week 2 through week 8. Okay, so this is when we have our little, he looks like a little tadpole. I mean, he's really tiny, you know. And so you have two areas that need to close during the embryonic development time. You have the top, which is called the cranium, okay, and you have the caudal, which is your bottom part of that little tube. All right, so these have to close. If they don't close, then you're going to have some malformations, such as spina bifida, all right, and hydrocephalus. When the cranium doesn't, top portion of that little tadpole don't close, you're going to have hydrocephalus. When the bottom part doesn't close, you get malformation as spina bifida, okay? So that's where giving her folic acid, I know we preached that chapters ago, folic acid, before they get pregnant is so important. And even if they don't come in before pregnancy, right in the beginning of pregnancy, you do what you can in order that it reduces the risk, the chance of this lady having a malformation related to an open neural tube defect. All right. So when you have hydrocephalus, this is what I'm going to point out to you. See how big his head is? It's because the ventricle in the brain, it's not draining. So what happens, you get all that fluid build up in his head, and he gets this huge head. Okay. Now that head on a little body, it's a heavy weight. All right. So you have to write this down. With hydrocephalus, you always have to support the head. And when you're feeding the hydrocephalus baby, you always have to support the head. Okay, so they do have a lot of nutrition problems because it's hard to feed them. All right, and so you can see his little forehead is all kind of pushed out. Okay, and his little eyes are bulging, and you can see they're kind of offset. You see one here, let me get my pointer. One is what, lower than the other. This guy here, you can see the suture line in his head. All right. So again, hydrocephalus. Oh, what happened here? Hold on. Okay. All right. What's your manifestations? Oh, my computer is having its own mind here. Hold on. All right. Let me go to my brain. Oh, hold on. Hey, hang in there with me. Just 1 second. Hey, let's go back up here. Okay. All right. All right. Sometimes computers are good when they work. All right. Brain teaser. All right. So let's talk about this. All right. So which assessment finding will the nurse expect for an infant diagnosed with hydrocephalus? You tell me.
2.
2.
All right. 2. It's a large and rapidly growing head.
Yeah.
Now tell me the what is the assessment finding if the baby, that is, okay, first of all, number 2 is correct. Okay. Tell me what the nursing assessment would be if the baby had a protruding tongue with a short, thick neck. Which one of those malformations is that describing?
Down syndrome.
Down syndrome. Absolutely. Tell me the malformation to a baby born with an inward turning of the ankle and foot.
Is that clubfoot?
Clubfoot.
Clubfoot. Good, good. Tell me what malformation is assessed when a patient has a hairy patch in the lumbar sacral region.
Spina bifida.
Right, but which spina bifida?
Sacral.
And that would be that little tuft of hair. That would be your spina bifida occulta.
Mm.
Okay, you don't see it, yeah, but there's usually like a little dimple. Okay, and so that's indicative of a spina bifida occulta because you can't see it. Something that's occult, you don't see, but it's there, and they usually have some type of abnormality that you can pick up and you can pinpoint it. Okay, good. You did good on that one. Proud of you guys. Okay. Now, yeah, go ahead.
Before you go back to upper,
can
we go back to downer? So what would be the difference between spina bifida occulta and spina bifida sciatica meningeal?
We're going to get to that.
Okay, thank you. No problem.
You're welcome. You're welcome, my dear. Yeah, we're going to get to that. So let's just finish up with this intracranial pressure. Remember, bulging fontanelle, right? We talked about overhydration, bulging, and that means it could be fluid or it could be what? Ink. It could be cerebral spinal fluid that's in the head related to hydrocephalus. Okay. A lot of babies, when they have problems, guys, you're going to see they may not feed good because babies don't feed well when they're sick. Okay. So they're a poor feeder. And then because they're poor feeder, they're more lethargic. Okay. They don't move around like they should. And with a lot of pressure in your head, you can stimulate the sphincter in the stomach to weaken and you get more vomiting. So, and we saw that unequal pupil size because the head has so much fluid in it and so much pressure. So, and then a lot of babies too have an abnormal high-pitched cry. If you ever heard a baby that was sick, real sick, they had this unusual high-pitched cry. So I have I love this little picture here because it does show you the ventricle in the brain and the cerebral spinal fluid doesn't drain. Okay. It doesn't drain like it should. So we have to help this baby. And so they put in this shunt. So they put this in and it goes behind the ear and it drains down into the peritoneal cavity. See? And this baby, it's a sick child. It has to have recurrent surgeries in order that the shunt works. All right. And these babies have to be on some type of phenobarbital because they're prone to seizures. And don't forget, got to support that head, especially during feeding. All right. So let's talk about our spina bifida. Okay, so let me get my picture here so you can see it. And here you have spina bifida occulta. You can see here the spinal canal, okay? And here's the spinal cord, all right? And here's the meninges. And basically, this one is not outside the body. There's no protrusion, okay? And so what you see is like a little dimple. If you ever see a new baby being that's born, you see the nurse and she takes her finger and she goes right along the spinal cord, okay? Right on the back. That's what she's looking for, if it's any indentation in that spinal cord. All right. So that's what we do. And here's your defect in the bony canal, okay? And that's where that little tuft of hair will grow, all right? This is your defect. All right, so nothing outside. Nothing outside. Okay, now this one here, all right, you have the cyst. So this is what? The meningeal seal. And you see the meninges. Yeah, you see the meninges that are outside. See here? Okay. All right, so that's like a sac or a cyst. And so the main thing is you have to protect that sac. Okay, because this is a living organ, this is a living part of this baby's body. All right. And so you have to protect it because you want to keep it alive. So what would you do? What would be the nursing action that you would do to protect this sac?
Cover it with gauze.
Okay. Would it be a wet or moistened gauze, or would it be a dry?
Moist.
Moisten.
Good.
Feeling.
Bingo. Hey. It'd be a moist and with sterile water.
Yes.
Right. Keep everything sterile. Okay, good. Okay. Now, if you had a little guy, a little patient, how would you position this child or baby? Like in bed.
Put him on his side.
Okay, I go for that. On the side, right? Okay. Would you put it on his back?
No, that could actually be hurting that protrusion.
Exactly. You got it. Now this one here it is the meningeomyelocele. This is what we call. Huh? Pauline, you okay? Okay. This is the meningeomyelocele, Pauline, where you have a defect in your bony canal. Your meninges are protruding, but guess what? The spinal cord on this one is protruding. Where on this one, the spinal cord was not protruding. This is I call the big guns. Everything is included. So, okay, you're back. Okay. All right. So here you have your spinal cord that's coming out. Okay. So this is your big one. This is the meningeomyelocele. Okay. And again, you had to protect. You do the same thing. You do the same thing as with the meningeocele, but now you have more. This child here has to have surgery. Okay, but they both have surgery, put it that way. But this child, this one here, they go to a hospital or a facility that will help them live. All right. What do you think it gets affected? What part of his body gets affected if all this is damaged?
Spinal column.
Okay, so what controls the bladder?
The lower extremities.
Okay.
The brain.
Yeah, they're going to have this one here. They have incontinence. They have bad bladder and bowel problems. Okay. And so these kids are prone to infection. Okay. They have to go to habilitation, where post-operatively that they learn to live with the limitation that they have. Okay. So it's very sad, okay, that this happens, and it's very sad for the family, and they have to go through. Now, when you go to habilitation, they're more positive there. You know what I mean? They think positively. They show the child, okay, you have limitation from the waist down. All right. Okay. Get you. Could be paralyzed too, of course. But guess what? We have what? Upper body. Okay. So they focus on upper body movements. All right. And make that child strong so that he can live a life. But it's a difficult life. All right. I'm going to move on. So we talked about folic acid already. We talked about correct positioning. It's in red to prevent pressure on the sac. You always have good care, adequate nutrition, right? Protein, right? Fruits and vegetables. Education, big time, and support to the parents. And you always want to prevent infection. All right, I'm going to move right on. So if I was to ask you a question, the nurse is caring for an infant born with spina bifida myelomeniingocele. That's the big one. What intervention will the nurse implement to protect the sac?
What, number 2?
Number 2. Good,
Yeah.
good. And be sure, now heads up everybody, be sure to read these, all right? Because you may just jump. Oh, there's sterile dressing. No, but guess what the word before sterile is? Dry. That's not correct. So read all your question answers, okay, before you jump to an answer. And I tell you, I always say this. You always want to ask yourself, what is this question asking me? And you'd be surprised, okay? And so yes, number 2 is correct. Good. All right. So let's talk about another problem that poor little guys could have. Is called cleft lip. So cleft lip, this maxillary and medium nasal process did not come together during the embryonic development. So it's open. All right. They have surgery, all right, to close it. The main thing you have to worry about this kind of baby is infection. All right. And they can't suck. And what else they can't do? They cannot cry. All right. So you want to make sure that you give them nutrition.
Yes.
They need nutrition, special syringe or bottle, and they'll do that repair. And it's called a chilioplasty, by the way. Just make sure this child doesn't scratch. You know how you have, surgery? You know how those sutures, when they start to heal, they get real itchy? But you don't want them to scratch because you don't want them to disturb that suture line. Because then if it opens up, they're going to have a terrible scar and right in front of their face. And that could damage them for the rest of their life. All right, so you don't want, so that's why we emphasize that. All righty, let's go on. Let's talk about the cleft palate, okay? These are things that didn't come together. And this one, the cleft palate, is your upper portion of your mouth. That has a lot to do with your speech, your dentist, your eating, even your ears, okay? These children of cleft palate have a lot of middle ear infections. Write that down. Middle ear infections. Respiratory problems and middle ear is because that passageway between the nasal pharynx and the nose is what? Is open. But, if you look at your cleft, if you feel your palate, now you know why is it so important. Okay. And this one actually, it didn't close, it didn't do right during the 7 to 12 week of gestation. All right. All right, the main thing about a cleft palate is I want it to what? I want it to close after surgery. And so there's no food through the straw. There's no sucking. Okay, because when you suck on a straw, think about it, what are you putting pressure on?
Your palate.
It's the palate. Right. So that's why you want to keep it clean, the mouth clean. So rinse out after feeding. Make sure that it's kept clean. And you have to be careful about their speech. And I told you about their dentistry, is because the teeth, when the teeth are formed, you have all these little, what we call buds up in the gum. All right. And so that the palate didn't fuse together during that time in utero, then that's going to damage those teeth that are already in there, the buds. Okay. So they have to have a pediatric dentist They have psychologists, they have pediatrician, they have nutritionists, because nutrition is also a problem to these kids, and they have a lot of ear infections. Okay, you got it.
May I ask something, please?
Oh, sure.
I don't know where my brain went, but they say no question is silly, so I'm gonna ask.
Okay, go ahead.
Do we have a difference with cleft the lips? I seen the lips. I think you just talk about it.
Yeah.
Can you have one without the other in terms of the cleft palate?
Usually now, what I've seen is the cleft lip, okay? And I haven't seen too many of the cleft palate, but I've seen more lip problems. That's a really good question. I'll have to find out for you, Pauline.
So what you discussed just now was the two of them together then?
Yeah, I discuss one at a time to give you what each of them stand for, like the cleft lip, and what the manifestations are, and how you take care of that sort of patient, okay? And then my other discussion was cleft palate. Okay,
well, they go together.
Now you think about it, maybe somebody can Google it, but you think about it, is that you have an opening here that didn't close.
Yes.
You could basically have an opening in the other palate too.
Yes, yes.
Yeah. But for right now, at this level, I'm just discussing each one separately and what the nursing care is for each one.
Thank you, yes.
Oh, you're welcome, Remember, what's the risk to a kid with a cleft palate?
Ear infection.
Ear infection, thank you. Okay, good, okay. All right, we just took care of that question. All righty. I have a couple more, and then I'm going to ask you some questions that maybe you'll benefit from. Let's go up to hip dysplasia, because I always like at least one question on hip. All right. So when you have a baby that's born with developmental hip dysplasia, you see here, guys, see how this buttocks is up and this one's lower? See, there's one's higher than the other. Okay, that's the kind of question you'll see. And then see here, this foot is higher, okay? That just means that what happened is the femur, top of the femur, okay, doesn't fit into the acetabulum, which is your hip, okay? It doesn't fit in there. It's supposed to fit like a glove, okay? Like here's your femur, here's your acetabulum, and it's supposed to fit right into that socket, all right? Okay, so when it doesn't fit into that socket, okay, then you have one higher than the other. Yep, so they're abnormal, okay?
Professor,
Pauline,
I'm just laughing. You remember when you were a kid and you took your doll legs out of the little socket?
Bingo! Thank you, Pauline. Yes, yes, yeah. We took those dolls apart, and then you try to put them back together, and you go, "Whoops! I shouldn't have probably pulled that leg out."
Exactly.
Exactly. I've been there. So that's what it is. It's just the head of the femur. So, and you see it more common in girls, and you see this show up actually when the baby starts to, like, as a toddler, begins to walk. He kind of walks like this, sort of what I do now, like this, okay? And so it's just the top portion doesn't fit into the acetabulum anymore. All righty. Let's go here. We already discussed this upper hair, so you all know that. All right, so I think this is just repeating itself. So I think we're to an end here. Hold on just a minute. Oh, let's talk about, okay, hold on, I skipped too much. All right, we have chromosomal anomalies, right? Okay, so there's two tests that can pick up Down syndrome. You have the one about 15 weeks gestation, that's called the alpha-fetoprotein test. But if you get back a test like that and it's positive, you don't make any kind of life decision based on a screening test. An alpha-fetoprotein test is just a screening test. It's not a test to diagnose, to make it like affirmative. So you do a amniocentesis to diagnose a abnormal chromosome, okay, test. All right, so write that down. Amniocentesis is the test that we do in order to confirm this chromosomal anomaly. You got that? You got the difference?
Yes.
Okay. So these kids are at risk when mom gets old. Remember we talked about advanced maternal age, 35 years and older, and daddies are 55. Their sperms are good till about age 55. Then they start to get some kind of difference in the way that they're formed, all right? So that's the test we do for chromosome analysis. And when we have a baby born with Down syndrome, is, you do see these babies at birth, okay? And you can pick up the kind of the abnormal size of the head and the eyes, and you can see his mouth. And it's very, very common that they have a protruding tongue, okay? And you can see that right away when they're born. And then here, they have a crease right across, is a line. Now, if you look at the palm of your hand, you don't have a straight line across your palm, okay? That straight line is called a simian crease, and that is also very common with a chromosomal anomaly baby. All right. They don't have a lot of muscle tone. They have what we call hypotonicity, and they're hard to hold and to feed, and they lose a lot of heat loss. And because of this hypotonicity, this makes sense. They would have more respiratory illnesses because they can't move the fluid around, okay? And they would have more constipation because they have low muscle tone. So that's why you see that. All right. Now let's
Sorry,
talk
Professor,
about,
what
yeah.
was the line that you referred to again?
Oh,
You would see
yeah, simian crease.
Okay.
Simian crease. Yeah, you can see that. And Hesse likes that kind of question. All right. And so you might see that on a Hesse. All right. And of course, the protruding tongue. All right. Now let's talk about this hemolytic disease of the newborn. Okay. And if you've been in my classes, you've heard me talk about it a lot earlier when we talked about ABO incompatibility. And when you have an Rh negative mom, okay, and you have an Rh positive daddy, you're going to produce a Rh positive fetus. Okay, so just remember that maternal blood, here's maternal blood, and here's a baby, okay? These two should never mix. The blood should not mix because you got a negative blood here, okay? And they're going to be on alert. And so all of a sudden you have this positive stuff coming in, right? And they go, oh, what's that? And they don't like it. They send out these antibodies, and the antibodies will go and attack all these beautiful erythrocytes or red blood cells. They're going to attack them. When that happens, your baby loses blood, and blood carries oxygen. And so babies get in trouble. All right. So what can we give mom to prevent this baby getting sick or severely anemic? What can we give mom during pregnancy? And then we give it to her after pregnancy. What can we give her?
Rogaine.
Rogaine. Now I'm going to tell you, Hesse likes the term Rh immune globulin. So it's Rh, and then parentheses, you got the D. So it's RHD immune globulin. So you may see that, and that's the same as Rogaine. All right. So here's my little drawing of, instead of my hand, so I was using, but you get the picture. You can see here, you have your mommy. She's Rh negative blood. Okay. Here's her baby. Baby is Rh positive. Okay. And so they get along as long as there's no mixture. But when you have mixture and you have this baby's positives, RBCs, and they're going in here, then they don't get along. So these Rh negatives are going to make antibodies to attack this baby's RBCs. All right. And then you have a condition called erythroblastosis fetalis in the infant, which is the baby is severely anemic because there's been massive hemolysis of the Rh negative blood and the Rh positive. Okay, and that's called erythroblastosis fetalis, and it can be easily taken care of when mom is given Rogam, and she gets it at 72 hours before she leaves the hospital. Okay, so before she leaves that hospital, we usually like to do it before, like within 72 hours of delivery. So before she leaves that hospital, she's going to get that, because what you're doing is you're always protecting like the next pregnancy. Okay, and if a woman has an abortion or she has ectopic, she's going to get Rogam also. Okay, because you can always have mixture. Now, another thing I wanted to touch upon with this other problem is under the errors of metabolism is when a baby is unable to take glucose and lactose and convert it to sugar. Okay, so what's happening, there's an enzyme that's missing, and you need that enzyme to help the liver. Remember, your livers are immature, so they need that enzyme to help the liver convert it. And when that is impossible, then she can't like breastfeed, because breast milk has the sugar in it. Okay, they're just not able to break it down. So if you can't break something down, you're going to have it what? You have it in the blood, which is called glycosemia, or you can have it in the urine. You're going to spill it either way. It'll be spilling it out in the urine. These things, if they're left untreated, can have bad effect on the baby. They can have cirrhosis of the liver, they can have cataracts, and they can have mental retardation. So on these kind of babies, again, early diagnosis is very essential. Okay, we got a couple more things I want to hit upon. That's another era of metabolism. You might see this one too. It's called the maple syrup urine disease. Now, we call it maple syrup. When you think of maple syrup, don't you think of your pancakes and you take this sweet maple syrup and put them all over your pancakes?
Sweet,
okay.
Yeah.
It has a sweet smell. Okay. All right. So the same thing, when these babies have a sweet smell to either earwax or their urine, you must say, wait, something's going on here. Because what's happening is that they have too much amino acids and metabolized from the body tissues, and they're not able to break it down, and therefore it gets too high in the tissue. So sometimes you have to do like hydration, and let me see what, hydration, and maybe sometimes peritoneal dialysis to get this under control. But usually a good test question would be, if you have a sweet smelling urine, the nurse picks that up. What is that complication? What is that? And you would to put maple syrup disease. Okay, that's how that would go. All righty. The next one you might have a question on was neonatal abstinence syndrome. Okay, NAS. And what happens is that you have a baby and mom has been taking drugs, put it that way. So this baby has been exposed to the drugs in utero, all right? And, we know that drugs do cross that placenta barrier, okay? It goes right straight to the baby. So your baby now is born what we call addicted to the drug. Now, he's okay in utero, and he's growing, it can be a little maybe small for his gestational age, but, he's okay. But when he's born, he's cut off. There's no more drugs, all right? And so this baby goes through withdrawals, just like anybody else. They have tremors, they're excitable, they're very excitable babies. You cannot console these babies, all right? So what's the best treatment that you would have for these babies? You tell me.
Swaddling?
Huh?
Swaddling?
Swaddling, right. Here it is.
You
And this
showed
is
it to me, right?
and this is how he cute though. And these babies, they're just miserable because they're looking for the drug. Their body is looking for the drug, and they're cut off. So they're very excitable babies. So you want to really decrease the stimulation in the room. You want to wrap them up real tight. And even, you think, rocking a baby, sometimes, in my experience, you just couldn't rock them because they've got more excitable through the rocking. So the best thing is to swaddle this baby. And sometimes you have to give this baby some phenobarbital. Okay. You have to give them some phenobarbital. They have a hard time sleeping. They're poor feeders. And so you try to feed them, and they're just, they're just miserable. They can be sneezing and yawning on and on and on. So it's just the best thing you could do is swaddle them.
Question.
Sure.
Is not a concern here? Like, do they not have irregular temperature?
Yeah, they may have just according to how their brain is, if they have a higher temperature or a lower temperature. But the main thing is your treatment is swaddling. Good question. Really good question. Love it. All right, let's see what we're up to here. How about a diabetic mom? Tell me about infants of diabetic moms.
When they come out, they become hypoglycemic.
Hypoglycemic. Absolutely. Absolutely. So you want to make sure that you test his blood sugar. Okay, good. Good. Got it. All righty. Love it. Okay. So what about these diabetic babies? They have what, hypoglycemic, and what else? They're big babies, right? Their face, it's almost like a cushingoid syndrome, where their face is so fat.
Face.
Yeah, round, right? Like a full, really rounded looking face. They could have some respiratory distress because they're going to get hypoglycemia, right? And hypoglycemia can go into what, respiratory distress. Yeah. How about hypocalcium? They can have low calcium levels in their blood. And then these babies also can have hyperbilirubinemia. Would they be jaundiced if they had hyperbilirubinemia?
Yes.
Yeah. Hyperbilirubin. Too much bilirubin circulating in their blood causes them to have a higher what? Bili level, which causes not only jaundice, but can cause what? Damage to the brain, right? So here you go. Here's our baby. Now you think this beautiful baby, right? And you think he looks healthy as anything, but he's not. He's a sick baby. All right. It's because mom was a diabetic mom. Okay. And so we try to keep them under control, diabetes during pregnancy, and they just grow very big. Hopefully this baby was born C-section. And when you have these big babies, they have a big head. Look at his shoulders here. See the shoulders? They're very wide. This baby would have a hard time delivering. You don't want to have a traumatic delivery with a baby that's sick, right? I mean, baby that's going to come out is going to have severe hypoglycemia. So you want to make sure that you do the best you can. And this baby went to the NICU and he's being monitored. All right. So what are my infant I have here? So you're going to monitor the nursing care, monitor glucose levels. Okay. When you do a heel stick on a baby, where do you do that heel stick?
On their little foot.
On the foot. You go through the middle? No. Where do you go? More on the back of the heel, like on the right. And there's a picture in your textbook as is exactly where you would stick the baby. Okay. So I'm going to monitor his glucose. I'm going to do his vital signs. I'm going to see any signs of irritability, because these babies, don't forget, they were drawing off all that glucose. Remember, mommy, they lived in mommy's tummy of a diabetic mommy. That means she had too much sugar. Baby was more hyperglycemic while in utero, but now when he's born, his sugar is taken away, and now he plummets down. Okay, these little guys can have tremors, and they can go in. Remember, respiratory distress. Remember that. Okay, we talked about that. Glucose levels below 40 milligrams per deciliter can result in rapid and brain damage. So do you want to monitor these babies' blood glucose? Yes, you do. Yes, you do. Okay, I think we exhausted everything. Let me see here. Let me go here. We talked about meconium aspiration syndrome already. All right. Okay, so we don't want that to happen because baby goes into respiratory distress. Please note what is being manifested by this baby when he's in respiratory distress. And I mean by nasal flaring, retractions, sternal or chest retractions, cyanotic, okay, grunting. Those another way they may put it, noisy respirations, that's grunting. May have some rales and bronchi, abnormal lung sounds. And remember, tachypnea, really rapid breathing, greater than 60 breaths per minute, with periods of actually he loses his breath of apnea. All right. So how are you going to take care of this guy? Got to get them suction for the meconium. Got to keep him warm. Always keep these babies warm. Give him some oxygen. Pulse oximeter on. Make sure he 92% or higher. You're good. Supportive care. Okay. And he's going to be in the NICU. This baby's going to be a sick baby too. All righty. Let's see here. I think I'm done. Oh, I threw this in there at the very last because I saw this on the quiz. And if you got it wrong, I sent you a note to let you know to look it up a little bit more. But the head. Okay, so the head, we have suture line going down the middle. Okay, right? See, I'm drawing my line on my head. Okay, when you have a swelling and it's back here in the crown area, all right? This is called caput succedaneum, and I'll spell it SUCCEDANEUM. And because it's here, you see, and my suture line is right here, it crosses the suture line. It crosses the suture line. All right, good. All right, so now the other complication I could have at the baby with at birth could be a caput cephalhematoma. All right, so have cephalhematoma. All right, so the hematoma is collection of blood. All right, so this collection of blood is just beneath that periosteum, and what happens is that you have a bulging. Now listen up. Where is it on my head? I'm pointing to on the side of the head. Okay, yeah. So that means it does not cross the suture line. See, because here's my suture line. It does not cross the suture line. Okay, and notice how those questions are asked about which one crosses the suture line and which one does not cross the suture line. Okay, and we already talked about fontanelles and everything else. Okay, now these about the math. Okay, so we're done our review. Congratulations to everybody that stayed with me. And just knowing, go make sure you know your rounding. Okay, and do me a favor on the math. If it says round to a whole number, round to the whole number. So make sure that you know how to round. So you know that if it's below 5, right, you don't go up, right? If it's above 5, you round up. All right. All right. So I put this in there for you, and then I gave you a little question there, and then you've had 2 worksheets now with math on it, so you should be okay with the math. You don't want to lose credit over that. And then of course your intake calculation, I put that on there in case you needed it. All right, I'm going to stop my sharing. Now, I'm glad you all stayed with me. All right, you guys are troopers, so I'm going to reward you, but let me ask you a question. Okay, so let's see. Oh, this is a good one. Okay, all right, ready? All right. So